Hi, everybody. Thanks for waiting. We're really happy you joined the webinar this morning. I think we're going to just get started. So,
hi, Ron here.
Hi, Ron. Thanks for joining.
Hey, sorry to be late. I logged onto the wrong meeting, I guess.
That's okay. We're glad to have you. So we'll start with some introductions. I'm Eileen Tonner, the project manager for the special study. On the call today, we have the principal investigator, Dr. Ron Chen from UNC, who's a radiation oncologist. And Dr. Chen will be giving a short presentation on the special study. After that, I will briefly go through the web form. And the head, Mohammed, is our software developer, and Amanda Franciscotti is the manager of the clinical research department. So, Ron, I think this is your part of the study, or the presentation.
Great. Thank you. And I want to first thank you all for joining the webinar today and also for participating in this project. What I would like to do is just introduce the study. The study is actually probably familiar or somewhat familiar to many of the registrars because I think many of you have participated in prior efforts looking at similar issues in breast cancer, colorectal, and lung cancer. And so the primary goal for the current project is to look at surveillance issues in prostate cancer. So the overall idea is pretty similar. Next slide. So just a little bit of background. Prostate cancer is very prevalent, and there are now over 3 million prostate cancer survivors in the U.S. This particular project is going to focus on looking at surveillance for recurrence after patients have had treatment. And so the idea here is after a patient has had treatment for prostate cancer, whether it's surgery or radiation, clearly, just like every other cancer, they need frequent surveillance to see if there's recurrence. And if there is recurrence, we want to be able to treat the recurrence as early as possible, and that can improve the patient's survival and perhaps even cure. But on the flip side of this, maybe sometimes we could be doing too much surveillance. And if we do too frequent a surveillance, then it certainly is a burden on the patients. It may be a cost for them. If the surveillance is too frequent, oftentimes if we do too many tests, patients can also have anxiety as well. And so this is a project to try to see if there is an optimal frequency of surveillance that is not too much and also not too infrequent as well. Next slide. And so there actually is no standard currently as to how frequently we need to monitor prostate cancer patients after treatment. There are various guidelines that have been published that range from doing a PSA test once a year to a PSA test every 3 months. So there's a very wide range in guideline recommendations, and frankly, the guidelines are based on just opinions of people who wrote the guidelines, and there has been really no prior study to see what the optimal surveillance frequency is. And the other thing about this project is perhaps people who are diagnosed at very early stages of prostate cancer, if the cancer is slow growing, perhaps the surveillance frequency can be less frequent. And patients who have more aggressive cancer, perhaps their surveillance frequency needs to be more frequent. But the current recommendations, the current guidelines don't take into account at all. Current guidelines recommend some frequency for everybody and do not distinguish patients based on how the risk of recurrence, the stage of the cancer, or whether the type of treatment patients had. And so in this big project, hopefully we'll be able to tease out some of these issues. Next slide. So the optimal approach to surveillance after prostate cancer is unknown. There's been really no prior research on this issue. The guidelines vary. It's not tailored to individuals based on their stage or risk or age or comorbidities. And we want to take up this retrospective study and perhaps in the future be able to do a clinical trial based on the findings from this project. Next slide. So we talked a little bit about this, but there's potential benefit and harm in terms of very frequent surveillance. The benefit of frequent surveillance is perhaps we catch the recurrences early, give treatment early, and that can improve survival. But there's also potential harm if the frequency of surveillance is too frequent because there's too many tests on the patients. The tests can cause both cost and as well as side effects, morbidity to the patient. So there may be a balance in the frequency that hopefully we'll be able to find through this project. Next slide. And so we would like to find perhaps the optimal frequency of surveillance based that's risk stratified based on the patient's risk of recurrence, and that maximizes survival and minimizes burden to the patients. We will also want to find the right frequency to reduce patient anxiety, and we want this to ultimately lead to a patient-centered approach that's individualized based on the patient's characteristics when we see them in clinic, and this will ultimately impact further research. It will also directly impact patient care as well for the millions of prostate cancer survivors that live in the U.S. Next slide. And so in this particular project, we are going to essentially look at 6 separate groups of prostate cancer patients. We want to look at, there's probably a different optimal surveillance frequency in each of these groups. And so the groups are based on the patient's risk at diagnosis as well as the primary treatment they received. And so when you all participate in this study and you get a sample of patients to abstract data, the sample of patients will be distributed across these 6 different groups of patients. So we're going to have a group of patients with low-risk cancer, which is a very early stage prostate cancer. They receive surgery, or low-risk patients who receive radiation, intermediate and high risk. And we hypothesize that for each of these groups of patients, the optimal surveillance frequency will be different. And so we'll be looking at these 6 groups of patients separately when we do the data analysis once the data are collected. Next slide. One of the important things is and we have information on this, one of the important things in grouping patients for data abstraction is the primary treatment that they receive. This is well defined in the manual that you will all receive, but the primary treatment is the first treatment that the patient received for their prostate cancer, and that is either surgery or radiation. And the radiation could be either brachytherapy, which is seeds, or external radiation. But so in the entire sample of patients that we will study, they will have received either surgery as a primary treatment or radiation as a primary treatment. And the order of treatment is how we determine what the primary treatment is, and that's how we put the patients into different groups for the data analysis. And so, for example, if a patient has surgery and then afterwards needs radiation, then surgery would be the primary treatment. And hopefully this is definitely explained in more detail in the manual. And the outcomes that we want to examine include the recurrence and survival of these patients, as well as receiving additional testing, treatment if they had a recurrence, side effects from all of this workup and testing, and whether there could be false positives in the surveillance tests. Next slide. And so the special study will also collect important patient information. Sometimes that could be potentially they may have some error in the current NCDB data, and so we will be updating the vital status for these patients during the abstraction process, updating the comorbidities and first course of treatment as well. We know in SEER cancer registries that there has been recently found to be there's a common error in PSA at diagnosis because of a decimal point error. And so we suspect that this may also be an issue in the NCDB, and in this special study, we will be asking you all to also recheck the PSA at diagnosis to see how much perhaps error we have in NCDB, similar to the SEER registries. We will also be asking to collect biopsy information also if patients have had a recurrence. Next slide. And so Eileen is going to go over the web-based data collection tool, and I think most of you are somewhat familiar with this if you have done the prior breast and lung and colorectal cancer studies. We certainly try to design this study in the web form to be similar to the prior ones with some tweaks because of the prostate cancer. The data collection instructions are to be mailed to you, and we are asking for your help in collecting data from 12 patients at each site. And we've built in some screening questions to help determine early on in the process if the patients that are randomly sampled are worthwhile going through the data collection or not. So we build in some screening questions so that you don't start collecting data on a patient and then realize that the patient is ineligible. And so we try to minimize the burden on the registrars by having these screening questions. And here they are. We want eligible patients to have evidence of medical records for 8 years or until they've developed recurrence or death. And so in a screening question, if you start looking at a patient and they've only been followed for a couple of years and they're lost to follow-up, then it's not worthwhile abstracting that patient, and then you would ask for a replacement sample patient. We want to collect records. The surveillance of these patients is often done by the urologist, primary care doctors, and radiation oncologists if the patient receives radiation. And so upfront, if you're able to identify who these doctors are, then the patient may be eligible. If you can't, there's no record of who the primary care doctor is, and then you will not be able to get the primary care records, and then the patient probably should be replaced. And we want, because PSA is the primary way patients get monitoring after treatment, we want the patients to be eligible if they have at least one PSA test result within 2 years of the surveillance period. So if you can't find any PSA result, then that patient is not worth abstracting and it should be a replacement. So we have these 3 screening questions to sort of help determine relatively quickly who's eligible and who's not, and asking for a replacement early on before you spend a lot of time on the patients who are not eligible. So next slide, please. PSA is key. In prostate cancer, after a patient has had treatment, PSA really is a primary way we follow patients to see if they had a recurrence. And so really to know how frequently people are getting monitored, and we need to know all the PSAs that patients receive during the surveillance period. So knowing all the PSA is key so we can determine the frequency of surveillance. PSA is also the primary way doctors decide if a patient has developed a recurrence. And so this is really probably the PSA frequency, the dates of those, as well as the PSA results for this special study is probably the most critical data for the study. Next slide. And so we want to learn about if patients have had a recurrence. And again, that's a lot of times it's based on PSA, but sometimes it's based on imaging or biopsy. And so we ask for your help in finding the first data recurrence, the type of recurrence, where it is, if patients receive treatment for the recurrence, whether it's surgery, radiation, or other types of treatment, the dates of those treatment, and the locations for those treatments. Next slide. And so in addition to contributing to, I think, knowledge on the optimal surveillance frequency in this large patient population, this special study also will help the NCDB in learning about the error rate of PSAs, and whether that's similar or more or less than what was found in SEER, and Gleason scores, and the dates. And I think that will really contribute to the overall NCDB data integrity. And it will also help the NCDB figure out recurrence. You know, as you all know, recurrence is a critical data element in cancer registries, and it's not very well captured in cancer registries currently. And this effort can help us learn more about that and see whether that's feasible to collect on a regular basis. And it will help us determine optimal follow-up for patients.
Okay. So now I'm just going to talk about the special study details and more in details on the web form. So participation in this special study is required by all COC accredited sites to fulfill Standard 5.7 with the exception of Veterans Affairs, Department of Defense, and pediatric facilities. We are opening this up to patients diagnosed in 2008, so sites with the reference date after 1108 are invited to participate if they have patients from 2008 only. For integrated network cancer programs, data will need to be submitted for each facility in the network. Merged facilities will participate in the study. We had a pilot study which was completed in January of 2017, and 7 sites were included. So for our study will begin April 17th, 2017, which is next Tuesday, and the deadline to submit all patient data is July 17th, 2017. So the link to the web form will be posted on Datalinks on the 17th. So I've gotten a couple questions like people haven't seen the link up yet. We haven't posted it because the study hasn't started until the 17th. So on Monday you should see it under Datalinks. Only registrars and co-registrars will have access. Data collection must be completed by a certified tumor registrar. This follows the requirements set forth by Standard 5.1, Cancer Registrar Credentials. So case abstracting is performed by a CTR. Non-credentialed staff who are abstracting and who are in the 3-year grace period are supervised by a CTR. So as Ron said, we have an inclusion criteria, so evidence that medical records are available for the patient for 8 years or until distant recurrence or death. For patients who received primary radical prostatectomy, the patient's urologist and primary care physician can be identified, and for patients who received primary radiotherapy, the patient's radiation oncologist and urologist and primary care physician can be identified. The patient has at least one PSA test result within 2 years after the end of primary treatment, and the registrar is confident in capturing PSA information for 2 years after primary treatment completion. The eligibility criteria made follow-up information easier later on, and that was the feedback from our pilot study. So we really made these eligibility criteria to make it easier for data abstraction later on to make sure that we have a complete medical record. The surveillance period, so the first treatment, there's only 2 possible treatments, either radical prostatectomy or radiation treatment, whichever was the first treatment administered after diagnosis. Radiation treatment includes external beam radiation and or brachytherapy, and androgen deprivation therapy is not considered first treatment. The surveillance start date, so for patients undergoing surgery as the first course treatment, this date will be the date of the radical prostatectomy surgery. For patients undergoing radiation treatment as the first course treatment, this will be the last date of external beam radiation or brachytherapy. If the patient had both types, then you would choose the later date. So this is the date that we want to start collecting data for the study. The surveillance period is the 8 years following the surveillance start date or until the date of the selected patient experiences a distant recurrence as defined in the data dictionary or the date of death, whichever is first. We have posted a follow-up letter on our website, so you can request records from physicians providing follow-up care for a patient's cancer. You can the follow-up letter can be sent to physicians providing follow-up care, and document listing of the special study data items can be sent with the letter, and we suggest that you at least determine within the first 2 to 3 weeks if all your cases are eligible or not for all 12 patients. So the pilot study said that it took a long time to determine eligibility, so it would be easier if you first just determined all the patients are eligible or not, and then start working on the data collection in case you have to go to different hospitals and get different medical records from outside institutions. So the following strategies were used by registrars during the prostate pilot study to help find complete follow-up information. So they would call and talk to the medical records staff or the nurse. they would go through all the available records and make a spreadsheet identifying the patients and all physicians they had been seen pertaining to the study. They would use the follow-up staff to help obtain the information and reach out to other registries for help. They would look at the urologist and or radiation oncologist notes and specify if the patient was disease-free, and then normally document what the previous PSA was and the date. And they would use that date to search for the PSA result. Most of the pilot registrars said that the biggest obstacle faced was realizing that the records were incomplete and going one by one to the outside institutions instead of just marking whichever patients are ineligible and getting replacements all at one time. So we recommend that you determine eligibility before moving on and abstracting the rest of the data. The web form review, so these are all the tabs on the web form. So there'll be the determination of eligibility, NCDB clinical information, where we will show you what's already in the NCDB, and we would like you to fact check and confirm that what is already in the NCDB is correct. And then the rest of the tabs, we ask you to abstract information that's not in the NCDB, so comorbidities, additional clinical information, mostly from pathology reports, and then we have surveillance tab, a PSA tab, testosterone scan and biopsy test, and then recurrence or new cancer diagnosis tab. So on the Datalinks homepage, registrars and co-registrars will see this heading under the Commission on Cancer Special Study. Underneath this heading, there's a link entitled the NCDB Post-Treatment Surveillance in Prostate Cancer PCORI. So when you click the link, you'll be directed to our web form for the special study, but this will not be posted until the 17th, which is the start date. On the first page of the web form, each registrar will see a drop-down list of the institutions which he or she is affiliated with. You would use your same login information as you would in Datalinks. So we'd ask you just use the same information to log in. And then you would pick your facility. And if a registrar works for multiple institutions, they should make sure to pick the right facility that they want to work under. You can also type in the facility name and not use the drop-down. So once you pick your facility, then you click Submit, and you'll be taken to a page with the list of 12 patients for whom you need to collect data. Each patient's accession number, date of diagnosis, date of surgery, age of diagnosis, and gender from the current NCDB records and the surveillance start date are shown. The surveillance start date is the period after which the information is being collected. This has been calculated for you. This is the date you should start collecting data. And we have also included a special study patient ID. This is a randomly generated unique identifier number given to each patient, and you should use this if you need to contact the study staff with a question about a specific patient. No patient or provider information, including the accession number, should be sent to the study staff to ensure patient confidentiality. So once you select the patient, then you will see the determination of eligibility criteria. And so if one of the questions is no, then you won't be able to see the next two questions because there's 3 eligibility criteria. And a patient has to have yes to all 3 questions in order to be eligible. Patients must be eligible before moving on to the other tabs. If no is answered for 1 or more questions, then you would click Submit, and a patient will automatically be replaced. If a patient is initially marked eligible and later found to be ineligible, use the Contact Us feature and explain why a replacement case is needed. The study staff will then replace the patient for you. So we also have a feature to collapse the section headers, so you won't have to see this top information, you would only see the accession number up here, and you would just do that by clicking these little vertical lines. And you will also see at the top of the screen the hospital which you are working for. If you're working for more than one hospital, this will be very helpful for you as you collect the data. We have a new feature of the web form this time, and it's the Add the New Test button. So however many tests you have, you can just click Add a New Test and enter all the information. And they don't have to be in chronological order. And this is for the PSA tab, the testosterone scan, and biopsy. So that will, and they'll ask different questions at the headers, but they will all have the Add New Test feature. The surveillance questions are mostly about the providers. So, and I also wanted to point out that we have links to the instructions at the top. So the general Rev form instructions and the prostate form instructions. We did email those out, and they will be posted on the website, and we mailed them via the U.S. Postal Service. So the instructions will be the main resource for the study. We have created a frequently asked questions page with questions and feedback that we received during the pilot of the study, and that can be found up at this tab. And we will continue to update this with questions received over the course of the study. If you have a question, that we advise that you check the frequently asked questions first, as this will be the quickest way for you to get a response. If you don't see your question listed, feel free to contact the study staff. And once you click this contact button, a separate page will open where you'll enter your name, email address, and subject of the message and your question. When you click submit, your message will be sent to specialstudy@facs.org, and you'll be copied on the message. If you prefer to email directly from your inbox, send all emails to specialstudy@facs.org, and these emails will be directed to the study staff individuals who are familiar with the data elements of the study. Please, again, do not send any identifiable patient or provider information over email or via this contact link. Use the special study patient ID if you are referring to a specific patient. Please don't send questions to the NCDB staff, as they are not familiar with the data collection process for the special study. So save it versus submit buttons. We want you to save periodically to avoid losing the data. If you save is different than submitting the patient. Saving just saves all your work, and submitting is you're submitting the patient when it's completely finished. So the web form will time out after 3 hours, so you want to make sure you're saving at the end of every session. We recommend waiting until the end to submit the cases, in case additional outside records come in. If a case is submitted and changes need to be made to it, you can contact the special study at facs.org. And cases will only be submitted electronically via the web form. There's no other paper submission. All communication emails for the special study are being sent from the specialstudy@facs.org email address through an outside server. If you have not been receiving these emails, follow up with your IT department and ask them to put us on the whitelist. We will also post information on the cancer forum. Contact us if no patients are listed after you log into the web form. If a patient has evidence of metastatic disease prior to the surveillance start date, so we can send a replacement patient. Any problems with the web form? You can send an email to specialstudy@facs.org. The special study staff will be checking the email regularly and will answer your questions. Always include the special study ID and do not send any PHI. So this is new for the 2017 study. We have a ticketing system. Email sent to the special study@facs.org will automatically generate a ticket. And ticket status will be emailed to the registrar once created and with each update. And so there's different updates you can get. So once you submit the email, you'll automatically get the request status, which means has not been opened by the study staff. You will get the open status when you see that we have opened it and we are working on the issue. There might be a time where we need more user information if we need more information from you. So we would be waiting on information from the registrar or user who asked the question. And then closed would mean the issue has been resolved. We're hoping to streamline the questions with the new ticketing system to make this a more efficient process because we've had to answer so many individual questions. We want you to note that the email is a different address from the previous special study, which was PCORI special study, but now it's just specialstudy@vax.org. Different communication mechanism than the 2015 special study, which is the ticketing system versus the shared email address. So we want you to really keep in mind that every time you email that email address, a ticket is created. So even if you respond, thanks, which is really, very nice and we appreciate it, we just want you to know that creates a ticket for us. So only email if you have a question. This is the best way to get the questions answered for the study versus the personal email addresses. So this is what we will be checking first. The electronic versions of the instructions can be found on the web form. Physical copies should arrive by Friday, 4/14, and let us know by Monday if you still have not received them. We sent them to the attention of the hospital registrar, who is listed in Datalinks. Instructions are split into two sections, general web form instructions and prostate study instructions, structured in the order of how the data elements are listed in the web form. So everything should be in order, and hopefully that makes it easier to follow. We will have weekly webinars, and participation in the webinars is not mandatory, but it is suggested. We're hoping that it will decrease all the questions that are emailed if you attend the webinars. The webinar content will differ each week. General updates, reminders, frequently asked questions, and helpful hints. We are offering NCRA CE credit. It will either be 1.0 or 0.5 credits depending on the length of the webinars. We are going to post the recordings of the webinars, and I can also post the PowerPoint available for you to view after each webinar. The registration links will be sent via email, and we understand that some of you haven't been receiving the emails, and we are working on that, and we have been once we found out about the problem. So even if you aren't receiving the emails, we're posting everything on the website, and it's a new special study section on the American College of Surgeons website, which is under the clinical research program section. So we're going to post the webinars, the documents, any announcements, and then we'll also still post the announcements on the cancer forum. So we're hoping that everyone is aware who is eligible for the study and they get every single resource that they need. Does anyone have any questions? We put everyone on mute just in case there is any background noise, but if you ask questions on the GoToWebinar page, we're trying to answer them as quickly as possible.
So this is Ron Chang here, and I'll just chime in. First of all, I want to thank everybody for calling in, and there has been a very active sort of question session being typed on this forum, and I've tried to answer them very quickly, and hopefully that would be helpful. Are there any questions people want to ask verbally as well?
I think they're all on mute. So the typing question is the best way to ask a question, but we can read them out loud.
Eileen, why don't you go through some of the questions that have come through that Ron has answered and the specific questions on here.
Okay, so someone wants a copy of the PowerPoint. We will be posting that on the website. Let's see. If our reference date is 1/1/2008 and we open the list and there's no cases, does that mean we are exempt from the study? I would say that you should email us if you have a reference date of 2008, and we have already sent out an email to the specific sites that we have specifically asked and have said that they are in the study. So if you receive that email, then you should have cases. Yes, I can go back one screen and so you can write down the website. Let's see. So in the study instructions, it asks us to document any testosterone use in the follow-up PSAs, testosterone effect on PSA. What is the rationale for not including this information for initial pre-treatment PSA? So there is no, that is a great question. There's no restriction on testosterone data entry. Testosterone prior to the initial treatment are welcome, and the Webform will accept those results. After the treatment, testosterone data are collected because it indicates if a patient is receiving androgen deprivation therapy, which is hormone therapy. If the testosterone is 0, it should alert the registrar to look for evidence of hormone therapy being received. The list of patients for your facility will be posted in the web form, to which you will have access on Monday, April 17th. So PSA is not recurrence for the registry. It is biochemical recurrence, but we can't document until metastasis. So the web form will collect each date of the PSA test and the result of the PSA. In the data analysis, we will use the PSA results and the date of the test to determine date of the biochemical recurrence. So there is some concern about giving testosterone supplementation in patients who have a history of prostate cancer, and there is some variability in the clinical practice on this issue. You cannot get the instructions sent to your home address. we have already sent these out to the addresses for the hospital registrar listed in Datalinks. We've had to exclude the VA and DoD sites due to their agreements with the COC and the NCDB. If you missed any part of the webinar, we will be posting it on the ACS Special Study website and the Cancer Forum. We will also post the slides. Radiation treatment includes proton beam. So if it's your first special study, when you speak of outside facilities or offices, do you need to get actual medical records from those facilities, such as urology, radiation oncology, and PCP? So the answer is yes, you need all the actual records, and that we really want the complete set. So same as in the last special study, we asked that registrars go to all the treating physicians for eligible patients, and patients usually go to outside providers. So this happened with 10 to 30% of the patients in the pilot study. So another thing we wanted to mention was instead of 2008, we are switching it to 2009 is the reference date cutoff, and for only those sites who have patients available in 2008 will we take those sites. So if you have a reference date after 2009, then you will be exempt from the study because you won't have any eligible patients. The physical forms that are being mailed are the same as the electronic version. It is the same document. We just wanted to give you the physical copy. Some people prefer paper over reading off a screen. We will post the program recognition numbers on the Cancer Forum and the ACS Special Study website. CEs will be provided for all webinars. Program recognition numbers and all the associated information will be posted on the ACS study website. We have sent emails to the hospital registrars and co-registrars. If you haven't received the email, you should follow the instructions in this webinar and contact your IT department. Some emails have been getting blocked in firewalls and spam folders, so on our end, usually we have your email address, whichever is listed in Datalinks, so you should definitely check with your IT department. So if a patient only had surgery at your facility and is followed by a private practice physician in the community or hospital EMR, will likely not have 8 years of data. If you can't secure records from the private practice, are these cases still eligible or will they be excluded? So we just ask that you please get the data from the urologist, primary care, and radiation oncologist, even if they are at another hospital and not in your EMR. If many of your prostate patients are referred from the VA patients seen at your facility were excluded from the previous study. So the patients will be excluded in this study as well. You'll get a list of the sample patients next week on the Webform site. So they will already exclude all the VA patients, so you won't get any in your queue. It's been determined behind the scenes. The program recognition number for this webinar is 2017-027, and we will be posting that on the website. We are going to mail one book for each facility. So and we sent it to the main hospital registrar, but everyone will have access electronically to the instructions. The ACS website is the American College of Surgeons website, not the American Cancer Society. I think we are over time. These are great questions, and we are still working to answer them all. We will be ending the meeting now, so thanks everyone for calling in, and we'll continue to answer your questions that you've typed up. So, and we will see you next week.